But let me introduce our guest here. So, David Shulkin, I think most people know who he is. He was the 9th Secretary of the U.S. Department of Veterans Affairs. He previously served as the Undersecretary for Health, appointed by the President. Prior to the VA, he served as the Chief Executive of Beth Israel in New York City and the Morristown Medical Center in New Jersey, and Chief Medical Officer of the University of Pennsylvania Health Systems, the Hospital of the University of Pennsylvania, and Temple University Hospital. In his spare time, no, I was joking. Former Chairman of Medicine and Vice Dean at Drexel University School of Medicine, Fellow of the American College of Physicians. He has been named one of the top 100 physician leaders of hospitals and health systems by Becker's Hospital Review. And so, David, first off, thank you very much for being here and doing this for us. And what you told me earlier today, after your tenure as the VA Secretary, this is actually one of the first times you've been out in the public talking about both the VA system and your own tenure. Let's get to what I'm calling the elephant in the room. And everybody that knew I was going to do this talk with you asked the same question. And the question is, what happened? If you don't mind just talking to us about that.
Well, I think everybody knows by now the president has his own style. And when you're a cabinet member, you serve at the pleasure of the president. And I was talking to my wife on the phone, and she said to me, I just got a tweet from the president. You've been replaced by his doctor. And so, you know, that's the way that things go in Washington. So it's a new normal.
And that's when you found out?
Yes.
That you were no longer the Secretary of the VA. You were there for a little over a year.
I was actually there for about 3 years.
But as this Secretary?
As the Secretary for over a year, yeah.
What changes were you trying to implement during that time period?
Well, you know, for me, I entered the VA as the Undersecretary. The Undersecretary is really the CEO of the health system through an appointment by President Obama. And I believed that we were making a lot of good progress under President Obama. I came to Washington because there was a crisis that had happened in 2014, the wait time crisis, where it became clear to the country that VA was not living up to its responsibilities, that there were veterans being harmed by not having good access to care. And I came to fix that, and we were well on our way to fixing that. In December of 2016, when President Obama was still there, we announced that we had established same-day services in every single VA facility across the country, so that if somebody had an urgent medical need, they would walk in and that issue would be taken care of. So when I became Secretary, again, much to my surprise, definitely not planned, my plan was to continue that progress and to use President Trump's style, which was unorthodox and allowed a certain amount of freedom because you weren't playing in a very strict sandbox, to not only keep that momentum going that President Obama had established, but to actually accelerate it and take some risks where I didn't think that, frankly, President Obama wanted to take those risks in the last part of his administration.
It's easy to beat up on the VA. It's a huge bureaucracy. In the media, we beat up on the VA. Other entities, politicians often beat up on it. But the VA itself has what I call the good, the bad, and the ugly. There's very good things about it and things that they do. A lot of my friends go to the VA because they also served in the military. And if you talk to them, they have gripes. They do have complaints. But at the same time, they'll say, if I get in with a primary physician, he's a great primary physician. If I get in with a specialist, it's typically a great specialist. It might take a while to get in. What do you see as the good part of the VA?
Well, first of all, I think you summarized it pretty well. The VA is the largest healthcare system in the United States, about 1,000 sites of care. And when you have a system of almost any size, but certainly that size, you're going to have variation in care. So you're going to have some places that are just delivering extraordinary care and some places that frankly are struggling. And that's what you would expect. If you go to any major health system in the country, University of Pennsylvania or Mount Sinai, you're going to have some star facilities and some that are still struggling. So what the press has found easy to do is to identify those facilities that are struggling, that are not meeting their responsibilities, and highlight them. And Look, that's part of their responsibility. It's frankly the way that we get better by having that type of transparency and putting the focus on areas that we're falling behind. The tough part about that is that it became such a constant drumbeat that the morale in the VA became really affected by it. Once you start getting your staff and your physicians feeling like they can't do well or embarrassed to say to their friends that, when they see them at their churches or their country clubs, I work for the VA, and people say, "Oh, I feel sorry for you." Then it really begins to be impactful. So what I was trying to do was I was trying to acknowledge when we had problems, because they were there, but also highlight some of the great things that we're doing. And I sense you recognize that balance there.
Now, with this talk here is essentially looking at how veterans can get that access to the VA and get that care that they need. You talked about kind of the hidden scheduling there people were waiting days, and unfortunately a few people died. A couple weeks ago, another news article came out talking about there was a hidden list of nursing homes that USA Today essentially forced the VA's hand, and they finally came out with these nursing home ratings, which weren't that complimentary to the VA itself. Why do they have those lists?
Why do they have lists that they're not publishing or being transparent
Exactly.
with? Okay. So one of the things that I believe a strong factor and motivator for improvement is transparency. I do know that's a very overused word today, but I will tell you it's been part of my strategy for improvement for about 25 years. I actually had a startup company about 18 years ago where I published the quality ratings of doctors and hospitals on the internet for consumers. First one in the country to do that, and I believe strongly that that is the right thing to do. When I talked about one of the things that in the Obama administration, they just didn't want to take that risk, it was publishing the results. The very first thing that I did when I became secretary was I published our wait times. And every wait time across the country, good, bad, or intermediate. We are still the only system, the only health system in the country that publishes its wait times. We then went to publishing our opioid use rates, the only system in the country who publishes their opioid rates. We then published all of our quality data in our acute care hospitals compared to our local hospitals. We published our firings and our disciplinary actions every week. So I'm a strong believer in this. When I went to my team and I said, it's time to publish the nursing home ratings about 9 months ago, they said, we hear you. We can't do it right now because we don't have the appropriate comparisons between VA and private sector, but we can get there. And they did release this about a couple weeks ago. And what it showed was there are good VA nursing homes, and there are some nursing homes that aren't so good in the VA system.
Now, you talked about the media keeping an eye on things and looking at kind of the bad things like the hidden lists and those types of things. When the media does that essentially force your hand or the secretary's hand to stop fires instead of looking at more of the long-term goals and how they can better treat the veteran overall?
Well, when you take a job in the public sector, that's part of the job. So you can expect almost every day that you're going to have some of those more immediate areas that you have to address. So that's part of the job. So you begin to use that to your advantage. And frankly, it's not just the media. You get, as secretary, I would get 20, 25 letters a day from members of Congress about specific issues. I would get inquiries from the White House, from veteran service groups, and from the press. And so you use that type of public pressure to actually help drive change. If you look at it defensively and you say, we're under attack, we have to hide, we have to come up with excuses and try to divert the attention, I think that's a losing game. And I don't see that it benefits veterans when you do it that way. So if you adopt the attitude that, look, this is a system that needs to be completely open. The press doesn't always get it right. Members of Congress don't always get it right. The VA doesn't always get it right. But for the most part, shining a light onto a topic, there is an opportunity to move the ball forward.
Now, with the VA keeping on the good themes and the good things they're doing, 75% of medical residents end up rotating through the VA. It's huge in medical education in this country. The VA also has one of the first electronic health record systems, and it's a very robust system. And we learned that as medical residents. It was one of the few ones we learned back in the 90s even. They keep pushing medicine forward too. A lot of research goes on at the VA as well.
Absolutely.
Is that correct?
Absolutely.
So these are all the good things they do.
Absolutely. The first liver transplant, the work that led to the CAT scanner, the radioimmunoassay, the association between aspirin preventing heart attack and stroke, the cardiac defibrillator, the nicotine patch, the electronic bar system that you use on every medical record now was a VA nurse who actually discovered that and patented that. So the VA is essential in terms of this research and in terms of training. And so many people, when they call for, well, what do we need the VA for? We could just give everybody a coupon and they could go out into the private sector. Well, we're the largest trainer of doctors, nurses, physical therapists, social workers, and after they train in the VA, they go out and take care of not only veterans, but all Americans. And the research is essential too. So I think that people have not really understood the importance of the VA in American medicine.
And why don't they hear that?
It's the old adage, this is your business, not mine, but the good news doesn't sell. It's not sexy. People don't like to hear about things that are going well. Our human nature is to focus on things that are going poorly.
Let's focus now on privatization, because that's a big issue, especially right now, looking at it. On the surface, it sounds great. You get immediate access, you can go to whoever you want to go to, those things you hear, all those promises. We know digging underneath the surface, that's not necessarily going to happen. What's your thoughts on that?
Well, I went to Washington, not because I'd planned to do it. I was minding my own business, running a hospital, and President Obama called and said, we need your help, we need private sector help. So of course I felt like, how could I say no? But when I went to Washington, I came completely without any opinion. I thought maybe I would come and say, this system is so messed up. There is no way to save it. We have to figure out a way to dismantle it and put it into the private sector. That was absolutely going to be a possibility I could find. Or I could find that it was a fixable system. One of the ways that I'm just an active learner, maybe I'm not a great book learner, but I like to learn by doing things. So first thing I did was I got my privileges at a VA. I picked the Manhattan VA and put on my white coat and started seeing patients. I've always seen patients as a CEO. And my first patient was a pretty humbling experience. I remember it like it was, right now. They wheeled him into my exam room. He was a African-American, 69-year-old Vietnam veteran, bilateral amputee, PTSD, substance abuse, actively on cocaine right then. And I was his doctor, and I had never used an electronic medical record. No, I hadn't. I'd always used paper. I vowed I'd be the last doctor in America to go to an EMR. So I clung on to it. But at VA, you have no choice. There is no paper. So he had a relatively simple issue, but I was trying to figure out how to use the EMR, and he quickly figured out he got the dumbest doctor in the VA that day. And he was pissed. He was also on cocaine. And he was cursing me out and screaming at me, and if it wasn't for my nurse, who was a probably 4'9" Filipino nurse who had been at the VA 25 years, she kept on saying, listen, it's going to be okay, it's going to be okay. Not to the patient, but to me. And got me through this experience. And when we finally got him on his way to get help for substance abuse and to get his problems taken care of, I really reflected that, and this is the truth, that in my prior practice, where I had just been 2 months before in northern New Jersey, I honestly would have called security, had him removed, followed by a certified letter saying, please never come back here again, because you are way too disruptive. And what the nurse reminded me is, these are our patients. This is what we do. You're going to get used to it, but we know how to handle these patients. And it became clear to me as I began to see more and more of my own patients that these patients would not do well in the private sector, in the 15-minute appointment slots and the quick reimbursement system that we have. And that's what the VA is for. And that was our responsibility when we sent them off to combat. And so, so I became a believer, not that the VA didn't need to improve, but that the VA was an essential system. Once I had that in my mind, then I knew the path I was headed upon. And so let me just get back to your question, John, and that's about privatization. Everybody in Washington wanted me to pick a political side. You know, Washington's more fractured and divisive than any time I think any of us can remember. You know, you have a home if you're on the far right, and you have a home if you're on the far left. And when you're in the middle, it's not so clear what you do anymore in Washington. But I wasn't going to do the politics. Frankly, I didn't want the job in Washington. I only went to help veterans. I certainly didn't go for financial reasons. And so every time people tried to pull me off, I just said, I'm not playing your game. So they say, are you for or against privatization? My answer is yes. Strictly, what privatization, the definition of privatization is, if you take any service that's government and you bring it so the private sector, who might be able to do it better, does it, that's privatization. I'm all for that. There are things that the VA should not be doing that the private sector can do better. But when you take a look at the patient I just described for you, I don't think the private sector would do that better. I think the VA needs to do that. So I was the middle guy. I wanted to take the things that VA wasn't doing well, the private sector could do well, and move it to the private sector. And I wanted to strengthen the things that VA did. And I'll shut up in a second, but I just want to remind people that 60% of veterans who get their care in the VA, and I'm not talking about you.
It could be.
60% carry a comorbidity diagnosis of a mental health condition. So the VA needs to have a very, very strong foundation in mental health and behavioral health care. And if there's one area that I believe the private sector is struggling with, is access to behavioral health care and good quality care for frankly, most Americans, unless you have enough cash to be able to go and hire your own team. Access to behavioral health care in America is a problem, and we just saw the suicide statistics for Americans. I mean, it's clearly, and the opioid crisis, and everything else. This is a real problem, and fortunately, I think the VA is set up to handle these issues.
Your end of your tenure and what the administration is looking at now did have to do with privatization to a certain extent.
Yes.
What were the differences there?
Yeah, good question. So the issue is, as I just said, I was trying to, and I was working very closely with Congress on this, to design a bill that would allow veterans greater choice, but not a system that just threw them out into the private sector. That I was a strong believer in, and you had mentioned this, that care needs to be coordinated. And VA has a strong system of primary care and a strong system of team-based care. And I believe that a coordinated system of care is better than just sending people out and letting them do whatever they want. And in fact, those that believe that it would be best for veterans just to say, here's your credit card or here's your voucher, good luck, we'll see you later, I think really ignore history in what we've seen with indemnity insurance and all the problems that most of us go to conferences hearing about, the gaps in care and the overutilization and inappropriate care. And remember, the VA system has no co-pays or deductibles, so they are unfortunately easy targets for doctors and others that want to essentially just sort of keep charging the credit card. So I was in favor of a system that was deliberate, deciding what services should be in the private sector, and that differs by market, and what services should be in the VA, but moving towards giving veterans more choice, because I believe it is the individual's choice. Those that were arguing that I was an Obama holdover, which is what I was constantly referred to the whole time I was there, and that I was arguing for the status quo, would say that because I was arguing for a system of care that made sense, that I was against veteran choice, that I was standing in the way of progress. What they wanted was complete, unfettered choice. So we had a difference of opinion. I knew I was politically on the wrong side of the administration, and I deliberately chose to stand for the principle that I believed in. Because frankly, the president could make a decision any day he wanted that he wanted a different secretary, and that was okay with me.
But what's the administration looking at now as far as privatization? Which direction are they headed in?
Well, if you take a look at the choice bill, what they have done is they have opened up the aperture towards allowing what I would call more unfettered access to care. Now, I think that Congress did a nice job of trying to put some boundaries around that. So I think that this bill that just recently passed that the president signed is, in general, a good bill. It is going to challenge the VA to really sort of go from a walk to a jog to keep up, to make sure it's got the right systems in place. But I think that I was very proud of the Veterans Committees for holding a strong stance on keeping the VA in charge of these systems. Now, it puts the secretary with a lot of authority. So I think the choice of a new secretary, the secretary's ability to make decisions about how healthcare goes in the future are going to be important things to watch.
And this is a big administrative post. So the secretary should have administrative experience, is that fairly key?
Well,
Told you I'd put you on the spot.
yeah. Look, the secretary is either going to need to have that experience themselves, or I hope develop a team with people who has that experience. And so we've all seen successful executives that don't necessarily have the deep subject matter competence, but that run a successful organization because they picked the right people around them. And so, since I left, there's not been another undersecretary that's been nominated or confirmed. We know that a lot of career people have left the VA since I've left. So I think that what we should be looking for is the ability to attract people with subject matter competence in health systems back into the VA. And, people ask me, they say, well, would you encourage people to go into the administration, particularly after I went through? And I say, absolutely. If we don't have the best people in the country willing to go, to step up, to help veterans and to serve the country, we're all going to be in big trouble if all we get is a bunch of political whacks that don't know what they're doing. And so I worry if people are stepping back and not willing to go. So I hope they do.
So part of my side job, I volunteer in a homeless shelter clinic. A lot of those homeless veterans that go there also go to the VA.
Sure.
I agree with you 100%. Going into the private sector, that would not work for them.
Right.
Is that one of the big issues, is getting their treatment, mental health in particular?
Yep.
Is that still a big problem with the VA, and are they headed in a good direction?
Yeah, the VA now has, as I mentioned before, same-day mental health services. The VA has a model of integrating mental health with primary care, so that you don't have to have the stigma of saying, I'm going to go to a mental health clinic. You can get it right in your primary care setting often. The VA uses telemental health now around 400,000 times a year because there aren't psychiatrists in many parts of the country where veterans live. But having said that, there's a shortage of behavioral health specialists. So if you look at El Paso, Texas, which is a border town, we are 19 psychiatrists and psychologists down from where we should be. So, but try recruiting to El Paso, Texas. It's a hard place to recruit to. So, but I think that this is a national problem, and so I think the VA is doing a great deal in this area, but certainly can do more.
So since post-Vietnam through 2001, the VA kind of went along at their pace and did what they normally did year to year. After 2001, there was a huge surge of veterans, and not just veterans, but veterans with very serious both physical and mental issues. How much of a burden did that place on the VA, and what's the consequence behind that?
The crisis that happened in 2014, the wait time crisis, was really the perfect storm of several different issues. One of it was the complexity. I don't even know if it was the number of people coming back from the current conflicts, but the complexity of their injuries and their psychological as well as their traumatic brain injuries, I think was beginning to overwhelm the VA, no question about that. But the real issue was not the Iraq and Afghanistan veterans. The real issue was the Vietnam veterans, because the average age of the Vietnam veteran now is 69 years old. And so what we're seeing is a huge surge of increase of medical needs, mostly from chronic illness, as the Vietnam veteran begins to enter the system. And so what happened was that, frankly, the VA has to request its money 2 years before the next budget, which is a system that I've told Congress doesn't work. I believe we need a system. When you make a decision to send people to war in 2001, that's when you should be budgeting for their health care needs, because you've just made a commitment to that young man or woman for the rest of their lives that you're going to care for them. So we should have known that 2014 was going to be a trouble year. And frankly, that's when Congress had to do an emergency authorization of $10 billion to say, well, I guess we missed this one, so we have to now get the veterans into the private sector. That was called the Choice Program in 2014. And ultimately Congress, I think, and the American people did the right thing by authorizing that, but it was totally unnecessary. We should have planned for that, and I think it should be mandated that when we send people into conflict, that's budgeted now over the next couple decades.
But it's still not.
It's not, because that would take a discipline and a budgetary authority that, quite frankly, would be difficult for them to do right now.
So I want to open up to questions here in a minute. First off, in just a second here, but first off, how many are veterans here in the audience? Okay, great. Thank you for your service, all of you. Before I open it for questions, what's the answer? What's the bottom line? What can help veterans get better access and better care from the VA, or in general?
Well, I just wrote an article that was in the New England Journal this past Thursday that basically probably confused some people who thought that I was completely anti-privatization, where I said the answer is you've got to open up the VA to competition. And what I mean by that is, when I ran a private hospital as a CEO, and I would hold town halls with my employees, I always knew the first question. The first question from an employee would always be, are we going to have a reduction in force? And I would say, it depends. And they would say, it depends on what? And I'd say, it depends on whether our customers want to come to us or the hospital down the street. And as soon as the patients in the area know that the outcomes are better, the service is better, the parking is better, and they stop coming to us, I can't hold your job for you. I think that needs to happen in the VA. And I believe that veterans, given the choice, if we're doing our job at the VA, should want to come to the VA, not be forced to come to the VA. And when you open that up to that type of attitude, I think you see things changing. Now, unfortunately, the cards are stacked against the VA right now because Congress is not providing the capital that they need to update their facilities. We have a physician here who works at the VA in the West Haven VA in the same town as Yale New Haven. Yale New Haven's probably put $500 million into their facilities in the last 10 years, and the New Haven VA looks like it's falling apart. I mean, when the wind blows, you can feel it, right? Yeah, no, I'm serious. I mean, I trained at the VA 25 years ago, and it's identical. I mean, and Congress has not authorized the capital for them to improve. They have great doctors and nurses. In fact, they share them with the Yale system. So in order to allow VA to successfully compete, we have to take away the hindrances. We have to say, you know, you can't hire a doctor, this is just one example, in the VA. Do you know what the maximum salary you can hire a doctor for? It's tied to somebody else's salary. The president's salary, right? You can't hire a doctor at any dollar amount more than what the president makes. Well, you try hiring neurosurgeons and cardiovascular surgeons and interventional radiologists, and you know we could start naming psychiatrists are beginning to get there too, and you know and you wonder why VA is suffering from a shortage of these things. Well, that's a stupid rule. Are we about caring for our veterans and getting them the best quality of care, or are we about keeping it at the president's salary so we don't offend somebody? I mean, that's just stupid. So we have to take away the handcuffs, let VA be a real system, and then let it compete. And if it's not doing a good job, then it shouldn't be there. Because this is about caring for veterans. It's not about somebody winning a political argument.
Excellent. Let me have some questions here. Right here. She'll bring the microphone to you. A couple of rules here. One, talk in the microphone because they're recording the session. And two, please, questions, not statements. That way more people can get questions.
Sure, I gotta make a little bit of a statement.
That's all right.
So you'll understand. First of all, he got a raw deal. And I don't know him, I've never met him. But I remember when General Shinseki was VA. I assume nobody here is from flag officer standing. What does a flag officer know about healthcare? Okay, so it started with a premise that on that floor on Vermont Avenue, that we're generals, we know about all this stuff. Here's what you will do, regardless of the fact that you're doctors dealing in 144 hospitals, nursing homes, clinics, 200,000 plus employees. You're going to do it this way because we're generals, we're going to tell you to do it that way. So, and you know the history of it, and so people then had to create waiting lists, fake waiting lists, real waiting lists, because the generals said we got to have this, and they didn't provide the wherewithal. I'm an attorney who represents tens of thousands of VA employees, and the healthcare is fabulous. As a veteran myself, Korea War. The problem is, in part, that the amount of money that has been allocated for the computer systems is woefully inadequate. And if you talk to the head of the computer systems in VA in DC, he says they come to work every day, and I just hope the whole thing doesn't blow up. And so you get an awful lot of problems. Let me ask, if I could, I just needed to tell you.
That's all right.
Yeah,
Appreciate
yeah.
it.
It seems to me that from the way you've described it and from my own experience, because I represent thousands of those vets, that the times that are coming with the VA may turn out to be much more difficult than what we've had. Because once they start to go to the private sector and they get ripped off and they go to the private sector in Fargo, North Dakota, right? South Dakota.
North Dakota.
And where are they going to find the physicians there that know anything about treating somebody who just came back with multiple injuries, multiple amputations, mental health problems, and opiate all in one guy.
Yeah, yeah. Well, look, I think that's exactly the position I was coming from, which is that if I felt that that was the best thing to do for veterans, I would have been on that side. But I think keeping a strong VA system and the men and women that you represent is an important thing for us to do.
Okay. Right here in front.
Both you gentlemen, Alan Frederickson, by the way, Omaha, thank you for your service. Thank you for the service to the VA. At this conference, there's been a lot of discussion about access to information for providers to care better for patients, and digital communication and various systems and interoperability and so on and so forth. Dr. Shulkin, your thoughts, if you would, on where the VA is there. You know, they're trailblazers in terms of electronic health record, and yet they're about to embark on a new chapter. Could you comment a little bit about that?
Yeah, I'm going to try to tell this story very briefly, but I think it's an important story, and this is an example where the VA can help the rest of the country. The VA was an absolute innovator and leader in electronic medical records when it introduced its electronic medical record in the 1970s. But the VA does not have an electronic medical record. It has 130 different electronic medical records. They literally are different systems. We just call it a single name. For 20 years, Blue Ribbon Commissions, members of Congress have called on VA to change that system and to use the same system as the Department of Defense, because we have the Department of Defense and the VA, and we spent billions of dollars getting them to be interoperable, and frankly, they're not. So I knew that if I did what the last 20 VA secretaries had done, trying to get consensus around this, it wasn't going to happen. So I went into a decision-making process by myself. I used something called the determination of findings, which had never been done in VA before, 3 times done in the US government, where I came out one day and just said, I've made a decision. I'm going to offer a single contract to the same company the Department of Defense uses, because I believe this is impacting patient safety of veterans, and I'm going to use that authority. I knew I would be sued. I was sued immediately, and the court upheld my decision because I made this on a factual basis. Again, I didn't have any political reason to do this. So now the VA will move towards the same system as the Department of Defense, a single system within the VA, by the way. But even more important for American medicine, I refused to move forward with a contract. So I did not sign a contract before I left because I insisted that the EMR companies break open their business lock on interoperability. And I put out 6 different standards that we needed to get interoperable care for veterans, and asked the provider systems in the country, of which 150 have now signed on a pledge, that if they're going to care for veterans, they too are insisting on interoperability standards with their EMR vendors. So we now have an opportunity to break the lock that the EMR vendors had been holding. This was never a technical issue. This was always a business issue for them. To break that open so every American can begin to start getting information when they go from a doctor or a hospital and then switch systems. So I think that will happen, and I think VA will be leading that in the future.
And if VA does lead that in the civilian sector, I can attest to the fact that, you know, if my clinic, I do EMRs, next clinic can't find out what I just did. It's just, it's impossible.
Right.
Katie back there?
Hey, I'm Katie, and I work in environmental health sciences, so how different environmental exposures impact health. But I'm also the daughter of an Army officer who was recently diagnosed with Parkinson's, and he has had great care from the VA, and I'm so grateful for that. But I'm wondering, as he's now going through the service-related illness, can you prove, can you not
Yep.
prove for
Yep.
retirement? When we think about veterans are exposed to environmental exposures and other things that the average American probably isn't, what role do you see the VA playing in thinking about reducing those exposures or educating people about those exposures before it leads to a health outcome? And maybe that's not the VA's job, maybe it's someone else's, but thinking about those upstream exposures that will lead to downstream health outcomes.
Yeah, very, very complex topic. The issue of the exposures and education is a DoD issue. Okay, VA gets involved once they're discharged. We know from history that our soldiers have been exposed to things that, in retrospect, we just shake our heads, right? They used to put them out in the desert and expose them to plumes of nuclear material to see what the impact would be. I mean,
But they had glasses.
they had glasses, yeah. Where I was focused, and I believe that this needs to be, again, something that the next VA secretary spends a lot of time and attention on. We make our veterans go through this documentation game of having to prove that they were exposed, that they were injured. We put them through appeals processes, which take on average 6 years to get resolved. Many die having this unresolved. Many go through years and years of suffering without VA benefits because they're fighting this. And I don't believe it should be that way. I believe that there should be a system where there is the proof and the burden should not always have to be on the veteran in the same way. But it's got to be done in a responsible way. And so I had announced that we were going to do a benefits commission to bring in experts in behavioral economics and experts in how the private sector does disability systems. And I certainly hope that that will continue.
Excellent. We'll start back here. And I can attest to the fact, too, that the disability system, when you get to the point where veterans have to hire lawyers
Yeah.
or bring them in to try and break through the disability system, I've seen tons of those.
Yeah, they have to almost, yeah.
I'm not a plant. I'm 69 years old, Vietnam vet.
Yeah,
10 years
Yeah.
in the system trying to get a PTSD rating
Right.
after I was misdiagnosed when I came out.
Yeah.
The choice program worked like a champ. 2 knees, the VA was backed up
Good.
6 months. And I used the choice program for 1 knee. When I went back for the 2nd knee, the cutter that I used refused because he wasn't paid.
Yeah.
So anyway,
Yeah.
PTSD,
Yeah.
I do get relief
Yeah.
from medical marijuana.
Okay.
Is that ever going to be an option
Yeah.
for veterans?
Yeah.
Thank
yeah,
you.
Yeah. So, the federal law, as you know, right now prohibits that. 22 states do allow that, including the one we're in now. The VA doctors are prohibited from prescribing, but they're not prohibited from asking about it and integrating it into the care. I have been a strong advocate for VA doing more research in this area to make it evidence-based, although I think that there is growing evidence that you can attest to it, right? So we have several therapies already that are evidence-based for PTSD: cognitive behavioral therapy, rapid eye movement therapy, prolonged exposure, and then I think that this is the next one that frankly needs to have the evidence looked at. I was actually encouraged when I heard the president talk a little bit about this, although I'm not sure he was talking about medical marijuana. I think he might have been broader about that. But I do think that it's time that the VA get more aggressive on this, particularly for conditions like what you're talking about.
Excellent. We have time for one more question. Here, Chris in front.
Since it'll be the last question, let's end on a high note, which I think is the alliance and partnership with the VA and the academic medical center,
Yeah.
hand in glove in many places, sharing talent. Any comments? Because, I mean, you don't have to go across the street necessarily. That person comes to the veteran then.
Yeah.
For the
yeah.
care.
Yeah, I mean, one of my very common stories I would hear from veterans and from doctors, they would go to the VA, they would get a opinion, you know, you're going to need a certain type of surgery, and the veteran would say, well, that's the VA, we all know about them, I'm going to go to the academic center and see the specialist. So they'd wait 3 months, they'd get in to see the academic specialist, they'd get into the exam room, and they'd say, doctor, I have this problem, what do you think I should do? And the doctor would say, I told you this 3 months ago when I saw you at the VA. Because 60% of all of our doctors are shared appointments between the academic center and the VA. It is the single greatest asset that the VA has. Started in 1945 when the VA was going through a crisis, and the head of the VA then said, I'm going to ask for help from the academic centers, the teaching schools. And since then, they've been side by side. And I believe that that needs to be strengthened and built upon. And in fact, that is our default system, that when we need to do joint recruitments, we go to our academic partners and we work with them.
Excellent. And thank you very much for this conversation. Just real quickly on the end note here, the second question everybody asked me is, what are you going to do now?
I'm going to do those things that actually I want to do. So I think that this issue of working on behalf of veterans is very important to me. So I'm going to continue, probably from an academic appointment, to continue to write and speak on these issues. And I'm going to continue to work with companies and others that are doing exciting things in healthcare. And rather than just do one thing, as I've always done in my life, maybe participate in a number of different things throughout all the exciting things happening in healthcare.
Thank you very much.
Thank you.
Appreciate it. Thank you, guys. Thank you, everybody.